Hello there, this is Dr. Ali, the midlife medicine woman or the hormone success doctor or whatever. And I am here to help you to understand the hidden gems in your blood tests. And you'll be able to apply these even to the blood tests you already have, that your general practitioner or primary care physician may have. And you can just ask them for a copy of the actual results. Don't just take their answers as read, because they're just skimming down loads of blood tests in a short period of time. And we are looking a bit deeper today. So no, you don't. Well, it depends where you are, Sarah. If you're in the UK, then you can ask your GP for a copy of the blood test you've had. But as I'm going to show you, the GP can't, at least in the UK, and also in insurance-based cultures as well, and Canada, where they have a similar state-run system. When you are pandering to, when you're trying to manage the health of a whole population, you can't afford to go to the depth that we're going to talk about, either in terms of how long the doctor has to interpret the results, but even the results that the lab tests that we can request. And because I have an understanding of both areas, I have a foot in both courts. I am an NHS GP in our state-run system in the UK, as well as being a private functional medicine doctor, which gives me the opportunity to spend much more time going in depth to results, as we will discuss. So if you're in the UK, you don't have to pay for a download. You can just ask the receptionist if you can have a copy of your blood tests, and in most practices that will be allowed. Some GPs are still a bit precious about how much their patients should be allowed to know, but for most places now you can get that, and abroad, yes, you can get copies of your results. But as I say, for the more in-depth lab tests we're going to talk about, they can be more difficult, and I'll explain why as we go along. So I'm going to start right away. Oh no, as soon as I've started, it's not allowing me to share what I wanted. That's insane. Ooh. I practiced beforehand and it was letting me have them both. Okay, well, we'll just have to do it from desktop then. That is so frustrating. Okay, so I'm going to get my notes up here. Yes. Get Lee in again. And I'm just going to stop my share and connect with somebody on WhatsApp and give them the link. Oh, yes, you're already here, aren't you? Oh, wrong one. Rosemary's already here anyway, so that's fine. Yeah, no more WhatsApp. That one's okay. That one's okay. Yeah, we're good to go. We're good to go. But I do need to just get my... Yeah, so I'm on holiday in Devon, Dartmoor. It was my birthday last Monday, and I'm really lucky and privileged to be able to have 2 weeks in Devon around my birthday. Isn't that exciting? However, I haven't been as relaxed as I might otherwise have been, I have to say. So let's just go back to here and to share screen. Hopefully I will still see. There we go. The joy of tech. And this is taking ages to load up. Okay. So right, so we're going to talk today about unraveling the secrets of your blood tests, and we're going to find some of the nutritional gems that are hidden in your blood and how to get some of the most critical tests even if your doctor can't order them for you. And I'm going to explain to you why that might be. And I am a medical doctor. That's what the MBBS means. I'm a member of the Royal College of GPs. 2020 means that's when I stopped my subscription, but I did pass all the exams that are involved in that. I have an MPhil, which means that's in physiology. So I really have done science to a deep level. This is the diploma of the Healing Animals Organization. I'm a trained animal healer and human healer as well. So I've gone into the spiritual side of things as well. And I'm a certified nutritional endocrinology practitioner. which is what opened my eyes to these additional levels of knowledge that aren't available to your usual GP and with the usual approaches. And I'm also currently doing the Institute for Functional Medicine training, which is also very intense. It's just wider recognized than the nutritional endocrinology training. And why nutritional endocrinology, which is managing hormone balance with nutrition? Because endocrinology is my passion and women's health is my passion. And that's where my passion for PCOS and menopause and thyroid in women comes in. So let me just see if I can get the actual. It's just not going to let me see my notes. It's just not going to let me. And this isn't the up-to-date version anyway. There we go. Okay, so here is a heart. Let's start with heart disease. So heart disease remains the most common cause of death worldwide, and especially in Western countries. So in America, in the UK, in the Netherlands, in France, in these westernized countries, Australia, New Zealand, the heart disease is much higher cause of death than the infectious diseases of the last century and the centuries before that. And one of the troubling things is that heart disease can often present with death, and we don't realize this. We don't tend to worry about heart disease unless we're over 65. And in actual fact, more and more, 50% of men, the first sign they have that they have heart disease is actually with their when they actually have a fatal heart attack. So they don't know in advance. And this is why in the NHS, we're so hot on prevention, even though people don't, it's not sort of recognized as much by the population as being so important. You think that the GP is there for you to see when you have an illness right now, a chest infection or something. But in actual fact, most of what we do in general practice is prevention. But we can go deeper than we do in general practice. And I'd like you to understand that. And I say 50% of men, but in actual fact, it's 60% of women. Women tend to have atypical symptoms. So they may have symptoms that don't sound like angina. So they may well present with a fatal heart attack. And in fact, that 60% of women have a fatal heart attack before they know that they have any sort of health of heart problems. And the reason this is close to my heart is because of the friends and family that I've had who've been impacted. My mum died in June from a heart attack, but it's not as simple as that, as I'll explain later when we come to blood sugar. My husband's best friend, Andy, died at the age of 52 last year. Oh, great. Great to have you with us, Nigel. I'm so sorry that you had the wrong link. Yeah, great to have you with us, Nigel. Sorry that you had the wrong link. So we're just talking about how important blood tests are in helping to look more deeply at our health. And 60% of women, 50% of men, their first sign that they have of any heart problem is a fatal heart attack. So Andy died at the age of 52, which is just astonishing. He had a heart attack, went into a coma, never recovered, and died within a few days. It was just heartbreaking for all of us. And then my mum had a heart attack in June and died, but that was not the first sign of it in her case. And I've seen in my practice, I remember a woman of 42 who had a heart attack. I was astonished. 42, it's just too young, isn't it? So what can we do to find out a bit more about what's going on? And we really can. So here we have the blood sugar, and I'd just like to reiterate how important blood sugar is in trying to work out people's risk of heart disease and of other illnesses, because we are more proactive in medical systems now at picking up people before they actually have the actual diabetes, when they have what we call pre-diabetes or impaired fasting glycemia. But in fact, we don't go enough in depth, or we could go deeper if people were open to it. And one of the problems is it's not just the doctors, but it's also that many people don't want to be as proactive about their health as they can be. And you've got to be willing to change the way you're living your life if you do find that your blood test suggests that you are at higher risk. And that's where the key is with this process. So what does blood sugar tell us? Using the ranges I'm going to talk about later, we can pick up diabetes long before it becomes diabetes or pre-diabetes or impaired insulin resistance, which comes before the metabolic syndrome that we're set up to pick up in the NHS. And we're going to be looking at some of the reasons that's so important, but diabetes and insulin resistance, so even this before it's diagnosed as diabetes, they put you at higher risk of virtually every cause of death and morbidity in the modern world. So it increases your risk of dementia, it increases your risk of peripheral vascular disease, it increases your risk of stroke, increases your risk of heart disease, obviously, and angina, but also increases your risk of cancer. So there are so many areas that this will increase your risk of. And I see every day people in the health service, people who they don't want to be proactive, and they don't realize that the NHS can't make you better. The NHS is actually a national disease management service. The same with the medical systems in other westernized countries. The health services are set up for managing disease, diagnosing disease, but not for preventing them and for keeping you healthy. That's really down to you. And that's why I'm passionate about helping you to take responsibility yourself for your health in this way. And let's take my mum as an example, or let's talk about diabetes. So my brother became diabetic at the age of 7. And that was type 1 diabetes, which is an autoimmune form. People, including him, don't think that there's anything you can do to prevent that. But any illness has many different factors, and you can improve it. So the thing with type 1 diabetes is that the pancreas tends to pack up completely with producing insulin, and that's why they have to go straight onto insulin, especially if they are diagnosed in childhood. But there is a newly recognized form of type 1 diabetes called latent autoimmune diabetes of adulthood, LADA. And anybody who works in functional medicine knows that contrary to popular Western medical belief, we can reverse autoimmune disease. And there is a lot we can do to change that progression of autoimmune disease, whether it's your underactive thyroid, which is autoimmune, whether it's psoriasis, whether it's rheumatoid arthritis, or this LADA, this latent autoimmune diabetes of adulthood. So my brother became diabetic before that even. I remember my aunt in the Isle of Wight. She was already blind because of diabetes. And I remember vividly the smell of the formalin and the pot of boiling water on the Aga, because she was diabetic in the days when you didn't have disposable syringes at all. And she had to sterilize her glass syringes. She had to reuse her needles. We are so lucky that diabetes care has come on so far since then. And she ultimately died still in my early childhood from the side effects, the sequelae of diabetes. Now, I'm not sure whether she had type 1 or type 2. It may have been before we were really distinguishing the two, to be honest. I don't know. And then my favorite aunt, who was also my godmother, Auntie Beryl, she developed diabetes in her late 40s, I suspect, maybe early 50s. And she died in her mid 50s from multiple organ failure as a result of that diabetes. And then my mum, so she first developed peripheral vascular disease, which is where you get the arteries in your legs furred up, just as with angina, the arteries in the heart are furred up. There's me gesticulating, but you can't see. So just as the arteries in the heart are furred up with angina and heart attacks, just as the arteries leading to the brain or in the brain are furred up in vascular stroke and vascular dementia, so you get that happening in the legs. And with my mum, the first sign was in the legs before diabetes or pre-diabetes was ever diagnosed. It was only later that she then developed diabetes, then developed heart attack in 2009, then had a coronary bypass graft because of the furred up arteries and an aortic valve replacement, then had 2 further heart attacks, and finally had a heart attack in June. But also at the same time, she had dementia, which is another sequelae, another side effect of diabetes. So diabetes causing these furred up arteries in the brain led to what we call multi-infarct dementia, which is dementia that increases in steps because of the furring up. So not all dementia is caused by furring up of the arteries, but most is in this day and age, because we have so many people walking around with this insulin resistance and metabolic syndrome, increasing their risks. Now, there's a lot of talk now about not worrying people. There was an article in the BMJ about private blood tests and how they shouldn't be done. In fact, there's been 2 articles similarly. But these things are all set up because of the way that the medical establishment is very precious about ownership of things like diagnosis and treatment, and they don't like people making decisions for themselves. But you and I know that we want to have that control over our own health. I know that you are feeling you want to be proactive about your health, because otherwise you wouldn't be here listening to me today. So let's move on. This is a picture of my mum shortly before she died, in the nursing home where she ended up. And it was a wonderful nursing home. And as you can see, I could still make her laugh. But it's, I know that if she had lived her life the way I recommend people do, then she wouldn't have had so much pathology towards the end of her life. She could have been active and her brain could have been more active for longer. And likewise, if I ate the way my mum did, ate and exercised the way my mum did, then I would be diabetic too. I know that because I have that strong family history. It's in my genes, as well as being a lifestyle thing. So, as I say, all these things are multifactorial. But if you are shown from the blood test to have a high risk of dementia or a high risk of diabetes, or if your genetic tests, which I also do, show you to be at high risk of these things, that's not the end of the story. These things are malleable. We can change our risk through all the things that we do and through the life decisions we make. So first of all, let's look at some of the critical tests that can detect disease before it even kills you. And I'm going to share some lab results. It's quite difficult because lab results in Canada, UK, and Europe are different to the lab results in America. I'm not sure which ones in New Zealand and Australia. I'll have to research that. So there are these hidden clues in your blood that your GP, your primary care physician, doesn't know how to pick up. And partly that's because in the medical systems, whether it's insurance-based or state-based as in Canada or taxation-based as in the UK, anything like that, they are restricted in what they can do and how long they can spend with you. And unless you are paying out of pocket, then they can't do more. So as I say, some days of the week I'm doing general practice in the NHS. I was a partner. I left being a partner because I was disciplined for recommending probiotics to patients and for my proactive natural health way of working, because it's not the way the NHS is set up or encouraged. And so I started doing locums. For a while, I was salaried, and that ended up in tears as well. So I do some GP locums. And during those, I just, in common with every other GP, only have like 30 minutes to go through hundreds of lab results. So all we can do is scan this list of blood results and decide which ones are high and which ones are low. And we can only go by the lab results that are there because, again, a healthcare system cannot cope with increasing the number of people diagnosed with a certain thing, or the increase in people that the medical establishment calls the worried well, the people who don't have anything, a disease state, but are worried about their health. Whereas you and I know that we can actually be proactive about our health. We're not so much the worried well as we're the proactive, preventing future ill health. And that's a very different thing. It's a very different attitude. My mission is to empower and inspire people to take back ownership of their health. And this is part of that journey. So here's me in my private medical practice. And now my practice is virtually completely virtual. And I have private clients. I have very few private clients, and I do groups and systems. So, and I have an online courses as well. So that's and my mission is to inspire and empower women and men worldwide, globally, to improve their health and take back ownership of their health and really understand their health through a deeper level. As well as being more connected to their soul and their soul purpose. So I have that healing-y side. I'm a blend of left and right brain, creative and science. It's been a privilege to follow this journey. And I always hark back to my roots. I was born and bred on a farm. I live in the country. I live for the country. My connection to nature and to wildlife is key. And one of the things that I noticed soon after I started doing medicine is how focused on pharmaceuticals we are. And it was sometime into my medical journey that they started reporting that fish were changing sex because of the sex hormones that were in the river water. And that's partly due to medications such as contraception and HRT, and partly due to the estrogen or xenestrogens that are in plastics. And this was impacting the fish. But I was amazed that nothing was done about changing the way we prescribe, because we're in this conveyor belt system that is based on the assumption that people will not be proactive about their health. So using natural contraception, really following your cycle really closely, it takes a lot of attention to detail. And because of complaints in the healthcare system, we can't risk people, women complaining to us that they got pregnant because we advised them to use natural family planning. And so we can't recommend that in the NHS. But you can choose these different ways forward. In addition, I broke my back when I was 17, just before I started medical school. So it's been amazing to be able to do yoga. It's been amazing to be able to move forward because I had 25 years of chronic back pain. So those of you who are in chronic pain, and I know some of you are here, I know what that feels like as well. But believe me, when we cover the inflammatory markers, you can understand and go deeper and heal some of those things. And we only touch on the surface of these things, I'm afraid, because I could easily talk for 10 hours on this, but I'm not going to today, I promise. And my aim for you is that you reach for vibrant hormonal health, and that you don't settle for anything less. I don't want you to settle for being tired and exhausted, having insomnia, having brain fog, putting weight on around the middle, feeling too tired to exercise, having chronic pain in your joints or muscles, fibromyalgia, all of these things. You don't have to settle for that, but you do need to be proactive about your health. And it's not about blaming your GP, as I have explained. Even I, with all my knowledge, I can't, within general practice, share this sort of level of things. So I'd like you to think for a moment, write down if you can, record in the comments, what's one thing you'd like to walk away from tonight knowing or feeling inspired to do? What's one key thing that you would like to learn about your blood tests or about your health that will make you feel able to move forward with this? And I'd really love you to record that in the comment so that I can know where I'm pitching this talk. So blood clotting, Sarah says, that's an interesting one. We're not covering blood clotting in depth this time. It's a complicated matter, especially in this day and age when, again, we're being proactive about preventing strokes by picking up people with atrial fibrillation, which increases the risk of strokes through blood clotting, and putting them on anticoagulants. And then that has impact on the rest of the body and on what you're told you're allowed to eat. But blood clotting is key. And also with recent events in the last 2-3 years, one of the things I'm going to suggest you make sure you get tested is something called fibrinogen. Some other questions. Oh my goodness, Sarah's just had a bilateral PE. That is tough. So I hope you're on the mend from that. You will be on some of those anticoagulants. Pam is asking about kidney and liver tests. We will be covering that a little bit. Lee wants to understand a bit more about about TSH, T4, and T3 and where they are optimal levels. I'll show you those optimal levels. But unfortunately, even as a GP in the know, I can't request more than the TSH. It's frustrating. And then Michelle says she has Hashimoto's. So do I. Welcome to the club. So you need to be looking at, oh yeah, we could form a PE club. So we need to be looking at with Hashimoto's, you need to be looking at an autoimmune diet. So yes, you need to be looking really carefully at those things. Absolutely, that primary doctors won't be testing your antibodies because if they're raised, the primary care doctor doesn't know how to reduce them. Whereas working with a functional medicine doctor like myself, you will be able to actually reduce them by going in depth into autoimmune diet. Yeah, that's absolutely true, Michelle. And then Hashimoto's. Lizzie has Hashimoto's and adrenal fatigue. Me too. Yeah. Lee has Graves. So you have had. So Graves is the other form of autoimmune thyroid where you get an overactive thyroid. Patent foramen ovale. So interesting that has taken so long to present to you, Lee. So the cardiologists don't think you need to worry. Yes, you could be at higher risk for clots, and also you may well find that. A PE is a pulmonary embolus, which is a blood clot in the lungs. So when people worry about a deep vein thrombosis from traveling, which is a blood clot in the legs, the reason it's such a worry is that it can throw a blood clot from your leg all the way up to your heart and lungs and kill some of the lungs, and that can be fatal. So that's why we're very edgy about picking up DVTs when you're traveling or after traveling, or when you have cancer, which also puts you at a higher risk, or when you are immobile for a while because of an orthopedic operation. And yes, fatigue would be an issue with patent foramen ovale. Interesting that they don't feel it's big enough to need surgery. Well done, Lee. Yeah, okay. And the high heart rate. Yeah. So so a high heart rate is not something we're going to cover here, but certainly working on a heart rate variability. I don't know if you use any of the devices that we now have available, but that can help you to monitor your heart rate. And then you can see the impact of meditation and mindfulness and breathing techniques on that. And you can look up something called heart math, which helps you to monitor and to manage your heart rate and your stress levels and your blood pressure. That's another story. So I'd like you to think also and record here, what would you be doing with your life if you had truly vibrant health and hormone balance? If you really had nothing stopping you and you really felt that you were fully in control of your health. I'd love you to write in the chat anything there. So I'd like you to focus. That's why this picture's here. So to get the most out of this training, please do turn off your cell phone, turn off Facebook, but although you can invite your friends to join us on that URL, stay focused because I'm going to go through some in-depth science It can be a bit overwhelming, but you will be able to access the replay for a short while, so you'll be able to go through it again if you want to. And open your mind and heart to what I'm going to say, because I don't want you to be resistant to it. A lot of people, particularly in the UK, are very supportive of the NHS, which is only right. We're lucky to have it. I'm supportive of the NHS, but I do appreciate that it's not the whole story. It's not perfect healthcare, nor can any healthcare be perfect if it's paid for by insurance or taxation or the state. And I do have to mention here that the information that I'm sharing today is not something to replace a one-on-one relationship with a qualified healthcare professional. It's not medical advice. It's just a sharing of my knowledge from my research and experience and training and the experts who have contributed to my training. And I encourage you to make your own healthcare decisions based upon your research and in partnership with a qualified healthcare professional. It's provided for informational purposes only, and there's no guarantees that you will achieve certain results as a result of this talk. So what's the danger of normal lab values? Why is that actually dangerous? I'm just going to have a quick look at someone's. Yes, so somebody was thinking there would be Rosemary would be more active and more ready to create and join in with activities that you used to love. That's absolutely my intention. And with every client that I have, it's about helping them to get back to being active and doing the things they love. So let's have a look here. The glucose level at the top, that's US figures. We're going to come to US versus UK, Europe, and Canada figures in a moment. But first of all, if we look at the glucose, you'll see that the laboratory normal range, which is based on the so normal ranges are based on the mean, the mean average, and then 95% of the population either side. So it only leaves 2.5% either end as being abnormal in inverted commas. So what they're doing is they're comparing you to the vast majority of the population. And I'd just like to remind you, yes, energy, Lizzie, absolutely. Energy is, I've just been so privileged with the techniques and tips that I have developed over the years. But so you don't want to be normal. You don't want to be the same as 95% of the population, because if you look around the high street, if you look anywhere, look around the doctor's surgery, look around the hospital, look around the shopping mall, you will see that 95% of the population, not necessarily well. And certainly we have well over 50% of the population. They say in some places 92% of the population is actually metabolically unwell. That means they are obese, overweight, or showing some signs of that insulin resistance I was telling you about. The insulin resistance that can creep up on us and give us heart attacks without us knowing, without us expecting it, without us being ready. Yeah, absolutely, Rosemary. So the population that we see at large, they're unwell. They're not well. They've got brain fog. I even attended a GP update training in person, and it was wonderful to be meeting in person after COVID. But the speaker, who was a GP, he was a little bit disparaging about a patient who came into him saying, I feel tired all the time. Now, I just have to explain that our job in the NHS is to pick up disease. We can't proactively make you better when you're feeling tired all the time. But there's a lot I can do even in the NHS, but not as much as I can do with the private clinic. But he was saying, try being a GP if you're worried about feeling tired all the time and having a headache, because it's become so much normal that the GP feels it's normal. Your GP, your primary care physician sees this level of ill health with migraines and headaches and feeling tired and unable to get up in the morning because you're so exhausted and falling asleep in the afternoon and having sugar cravings and coffee cravings. That's considered normal, even by your GP. They don't realize how much energy and how much headache-free and sleeping well you can get if you look at it more closely. And that's why we have these are the normal ranges, 65 to 110 in US figures. And the functional medicine range is the optimal range where we're trying to get optimal health is 65 to 89, so much closer. Uric acid, for example, 1.8 to 7 in normal terms, 3.2 to 5.5, so much closer, both at the top and the bottom end of the range with uric acid level. Blood urea nitrogen, or urea as it's called in the UK, normal in the medical establishment sense is 8 to 28. But if we go tighter and we spot that things are going awry a bit sooner, we have a normal range of 13 to 18. So you see that this can be very powerful, but it does mean that you've got to take your health into your own hands. Just going to read a couple of messages. Is there a group admin for the chat? It's just me, I'm afraid, Lee. Yeah. How sad that the GP trainer was counting this as normal. And I know there's so much potential for improvement. So here I've translated the US and the UK, or standard international units. Okay, so the lab minimum and maximum for US is 65 to 110. Now, in terms of the UK, this would be 3.6 to 6.1, and that's normal min max. So this is the normal ranges. Now, if we want optimal health, we want 75 to 89 for the US, and we want 3.6 to 4.94, so 3.6 to 5 if you're going for functional ranges, and we're trying to keep your blood sugar more tightly controlled and feeling better. And then the HbA1c, which we're going to come to later. I'm going to explain what that is in a moment. But the HbA1c is looking at the glucose glycosylated hemoglobin. So hemoglobin molecules where glucose is stuck to your red blood cells. Now, because your red blood cells last 90 to 120 days, this change is looking at your blood sugar over the last 90 to 120 days. So we use it as a 3-month marker. And US are using these levels, the percentage, whereas we switched in 2011 to millimoles per moles. You may remember all about moles when you did chemistry, O-level, GCSE, or whatever, but it is complicated. But anyway, 29 to 41 is considered normal, and in the health system, we only recognize somebody as being pre-diabetes if it's above 41. But if you really want optimal health, we want that to be 26 to 31, because guess what? If it's at this higher end, 31 to 41, you're already getting damage to the retina, damage to the kidneys, damage to the nerves in your feet and to the arteries. And the nerves are supplying the arteries as well. So, that's why. So there's a couple called Lee, and welcome both of you. Right. So let's look at these ideal ranges. And again, this is back to the US markers, because I haven't had time to translate completely here. But we have what we can see here. If I remove my face, we have got this progression, which is not inevitable, I hasten to add. There's ideal health, there's insulin resistance, there's metabolic syndrome, which is where you've got insulin resistance and some other symptoms like more central weight gain, and you're already getting damage. And then diabetes is considered greater than 120. And with the lipids, which we're going to come to later, again, the UK and the US values are very different. But you can see that raised triglycerides are a sign of insulin resistance. And we often forget to think, I forget in my general practice work because I don't have time. But if the triglycerides are high, it actually means you've got insulin resistance. It's not just a case of your high it's not just the high fat diet or anything like that. Oh my goodness, I think an illegal dog's just come upstairs. I didn't shut the gate. Right. And then the fasting insulin, which is something that we very rarely measure in the UK. Yeah. Yes, so fasting insulin, we don't really measure this in the UK. No nudging, thank you, Ivy. So fasting insulin is something we don't tend to measure in the UK at all. Maybe the diabetologists might do, But this can give us really great keys. If the fasting insulin is high, it really does show that you've got this beginning of insulin resistance, and it's a sign that your insulin level is too high. This can lead to insulin resistance. Your insulin receptors on the cells are getting blind to the insulin, so you get this vicious circle of high insulin and then the receptors not responding, so you release more insulin. And this is what leads to diabetes. And it's not the obvious. It's not just about sugar. It's about flour. It's about things. There are other things that spike your blood sugar. And here's the HbA1c values. And again, you can see we've got this progression. Rather than waiting till you've got metabolic syndrome or diabetes, you can start changing things at this level and turn around your future so that you're not getting the dementia and heart disease and vascular disease that my mum had. So we're going to talk about 5 important blood marker categories today. First of all, we're going to talk a little bit about nutrient imbalances. And it's interesting how much we can pick up from normal blood tests that your primary care physician will have requested. Secondly, we've got markers for cardiovascular health. So we've touched on that a bit, but we're going to go in a little bit more depth and explain some more in-depth tests that you can get done. We're going to talk about blood sugar markers. As you can hear, I'm passionate about these because not only my mum, but so many people are having ill health because of these markers being high. And then we're going to talk about anemia markers and immune system imbalance markers. Now, this time I'm not talking in depth about thyroid and sex hormones, although they are important, because from a functional medicine point of view, if you want to improve your thyroid and your sex hormone balance, you actually need to start by improving the nutrients, improving your gut health. We're only touching the surface if we just treat with hormones, and that's the way we do it in the NHS and in the insurance-based systems, but this can go into a bit more depth. So let's start with those nutrient imbalance markers. And the reason this is so important is because most of us are deficient in essential nutrients. And some of it's as a result of our lifestyle, most of it is. Some of it's as a result of our genes, which is why it's worth having your genetic analysis done with a functional medicine doctor like myself, because I can help you select certain subtypes of supplements. For example, I know that I can't convert from beta carotene to vitamin A because of my genes. So knowing this much depth enables us, it empowers us, it enables us to make the right healthcare decisions. And partly this is drug induced. So many people are walking around on statins, on anticoagulants, on proton pump inhibitors. So that's medicines like omeprazole, Losec, lansoprazole, rabeprazole. These things have important impact on our nutrient balance. So let's have a look. Let's start with vitamin D. That's an easy one. Now, vitamin D testing, it's crucial. I ask for vitamin D levels all the time, even in my primary care. On antidepressants. That's challengingly, and I hope you can reverse it. And I haven't not really going into mental health on this, but getting these things right can improve your mental health enormously as well. So with vitamin D, there's the lab test normal, which is 32 to 100 in America. In the UK, I think it's because we measure 1 and 25 hydroxy vitamin D, so it's a slightly different measure we're using. So lab normal in the UK is let's see, it's 50 to 200. So that's what's normal in the UK. Canada is probably the same. I have to do a little bit of research. But then when we look at functional levels, in the US, we want them much higher, 70 to 100. For me, I aim for 75 to 200 in UK terms. But the thing is, you do need to ask for your actual results, not just the doctor's interpretation of those results. Yeah, that's great, Lee, that you actually reversed it when you stopped your antidepressants. Yeah. So Lee, one of the Lees who is attending, she got diabetes as a result of antidepressants, but reversed it when she stopped them. So well done. So with the vitamin D, in the NHS, I request it all the time because I have cured so many people's chronic fatigue syndrome and fibromyalgia just by getting their vitamin D levels not to the normal levels of 50, you know, in the UK, 32 in the US, but to the optimal level, 75 in the UK. And but I, but whenever I request it in the NHS, there's these lists saying what are you requesting it for, and tiredness and muscle pains, fibromyalgia, and they're not listed as reasons for me to request it. So the practices that I locum at, they're probably getting their wrists slapped for asking for too many vitamin D tests. That's the way it works in these systems. But if you want to be proactive, you can request this. You can try getting it from your GP, and if they won't do it, then you can get it done privately very easily. It's a blood spot test for vitamin D, and not that expensive either. Yeah, that's great, Lizzie. Well done. She's asking for the actual numbers, but you can actually ask for a printout, and that just gives you so much more power, especially with what I'm going to share with you later on. So let's look at a plan. So we're aiming for an optimal range of, in the UK, 75 to 150. Now, generally, if it shows as less than 50 in the UK or less than 32 in the US, your standard physician is just going to say that's normal. So you want to look at the range, and vitamin D supplements are easy to buy now. Do look at the quality, though, because the quality does vary. I recommend you look for a pharmaceutical-based supplement, pharmaceutical grade supplement, because then they're guaranteeing that the amount they say on the bottle is in every tablet. And most supplement providers don't do that at all. And when they've taken them off the shelves and measured them, some of these supplements don't have any of the active constituents they claim they have in them. And some of them have herbs that are detrimental. So really is worth looking for a pharmaceutical grade supplement. And I can make recommendations for that if you want. So if your vitamin D is really low, I recommend 20,000 units every day for 6 weeks and then retest, or 20,000 units a day for a month and then 10,000 units for 2 months, then retest. However, if you are going for these higher levels, I would recommend you get what we call a bone profile done, which looks at the calcium and the way the calcium's working at 1 month, because vitamin D is very closely related to calcium metabolism. And if you have too much vitamin D, you can precipitate high calcium levels. So, and then at 3 months retest. So if you are on these high levels, if they're prescribed in the UK, then you will be allowed to get these tests done. But often people don't bother. But the important thing is not to stay on these high levels for more than this amount of time. You're welcome to take a screenshot of this. And then, so if your level is 60 or above in the US, or 75 or above in the UK, then you probably only need to supplement in winter. And it's worth getting a test done privately in the winter and in the summer so that you can compare and see how well you're converting. And one of the things is, yes, DEXA scan, that's a different issue. That's around, that looks at bone density. Yeah. So let's look at methylation nutrients. Now, methylation, there's been a lot of talk about methylation and MTHFR lately, but your genetics isn't just about the MTHFR gene, and I don't want you to focus just on those genes. Some of you won't have heard about them because in the NHS, this sort of discussion is suppressed because, again, they don't want people worrying. They don't want people being diagnosed. They don't want people taking their genetic test to the GP and expecting the GP to understand them, because they won't. You need to go with somebody who understands this approach to health, this proactive approach to health. So methylation is like a hot potato. So let's look at the blood markers that we can use to pick up a problem with methylation. First of all, homocysteine. This is not a standard UK blood test. We can request it privately. It's quite complicated. I think they need to centrifuge it at the time of it that it's taken. But they may have changed that slightly. sorry. Mean cell volume, this is key because this is present in every time you have what's called a full blood count or complete blood count done. And this can show us if the mean cell volume is large, as we'll see later, that does suggest there's a problem with the methylation blood markers, which are folic acid, which is vitamin B9, vitamin B6, and vitamin B12. Methylmalonic acid, now I'm seeing this more and more being able to be requested in the NHS, but most doctors won't be familiar with it. Folate and metabolites, and vitamin B12. So vitamin B12 is available in the NHS, but we're really only supposed to request folate and B12 if somebody's been shown to be anemic. And then with the private system, we can request anything we want, of course. And so some of the markers of low vitamin B6 are having a low level of these, which are some of the liver function tests. Low levels of mean cell volume, mean cell hemoglobin, and mean cell hemoglobin concentration. Low hemoglobin, which is what we see with anemia, hematocrit, and low red blood cells, or a high level of iron or red cell distribution width. We'll come to RDW when we cover hematology in a moment. Low vitamin B2 or thiamine markers, and this is particularly common in people who are alcoholics and are not eating well. High tryptase, yeah. That's complicated, Michelle, certainly. So the low vitamin B2, if you've got a high anion gap or a high fasting glucose, this can simply mean that you have a low vitamin B2 level. And if you have low CO2, low hemoglobin, low hematocrit, and low LDH, again, one of the liver markers, this can be a sign of low B2. So you can see, in functional terms, we can do a test called nutrigenomics or metabolomics, which looks at your actual levels of these vitamins. But those are very, very expensive tests. We're looking at £800 plus very often. And we can pick up a lot just from the normal blood tests that you have. Let's look at vitamin C. So vitamin C can be low if you have a high level of alkaline phosphatase, red blood cells, mean cell volume can be high, but none of these are specific. You're seeing here that these can be markers for several different things, and it's quite complicated teasing out what is the cause of this particular high or low mean cell volume, for example. And low vitamin C can be present if you've got a low hemoglobin. This is partly because vitamin C improves iron absorption. So if you are anemic, whether you're taking supplements or relying on diet, if you take vitamin C at the same time as your iron-rich foods, that can help you absorb it. So vitamin C is in all these amazing fruits and vegetables. And they're less present if you have orange juice rather than oranges, or if you have a prepared meal. So if you can prepare things as fresh as possible, the vitamin C deteriorates very quickly. And so that's why I also take a vitamin C supplement several times a day myself, despite a perfect diet. So indirect indicators of minerals in the blood include, if there's a low zinc, it could be showing as a low alkaline phosphatase, which is one of the liver tests, or a low white blood cell count. So interesting. I never knew that you could tell about the zinc from the alk phos. Amazing. And, generally in primary care, we would ignore a low alkaline phosphatase because what we're really looking for is it being high, being a sign of either bone problems like bone metastases or Paget's disease, or a sign of liver problems. Molybdenum, so it's another essential mineral that's needed in tiny amounts and is particularly important in diabetes. Zinc is important in diabetes and thyroid. Selenium is essential in thyroid. So molybdenum could be low if you've got a high serum iron or a low uric acid. Selenium is particularly important for the conversion from T4 to T3. Selenium is present in Brazil nuts, by the way. So if you've got a low free T3, it could simply be that you've got a T4 to T3 conversion issue, one of the causes of which is selenium deficiency. And then we have copper, and copper and zinc have this important relationship in that if you have too much copper, you can have zinc deficiency, and vice versa. It's very important that they're in balance, and our bodies are so good at what we call homeostasis, keeping things in balance. Low stomach acid. So this is so important because low stomach acid can present with indigestion and heartburn, and we just don't recognize this at all in in Western medicine, because if somebody comes to you with heartburn, we as doctors are addicted to getting quick results and reduction in symptoms, and the patients are too. And so what do? We give them some omeprazole or lansoprazole. We give them a proton pump inhibitor. What does this do? It stops your body producing acid. It's stopping you produce the acid that you actually need. And then what happens when you have low stomach acid, whether it's because of the reducing with age, which it does, or because you're on these medications, you get low levels of chloride and calcium and phosphorus, protein, albumin, uric acid, ferritin, iron, and hemoglobin, because you can't absorb them if you don't have enough stomach acid. You may have high carbon dioxide, high mean cell volume, high mean cell hemoglobin, and the blood urea nitrogen or urea can be either high or low. But I really want you to see the protein and albumin. You will have protein deficiency if you don't have enough stomach acid. And if your protein and albumin are low, and we see this so often in the elderly, it could be because you have low stomach acid. It could also be because you're not having enough protein in your diet. And we do see that a lot in the elderly that we see in general practice. Yes, Michelle. Yeah. I hope sometime you'll be able to. Yes, levels of stomach acid do decline with aging. Exactly. Yeah, all the side effects of low stomach acid. And the reason low stomach acid results in this acid reflux is because the valve, so there's a natural valve in the diaphragm where the esophagus passes through. Let me see my picture. So there's a natural valve in the diaphragm, which is a muscular sheet separating the lung area, the thoracic cavity, from the abdominal cavity. And there's a natural valve created by these muscles. And this is where the esophagus goes through. Now, if you don't have enough stomach acid, the stomach acid helps to keep the valve tight because it keeps the muscles stimulated. If you have low stomach acid, these muscles loosen, which then allows what little stomach acid there is to reflux up into the gullet. It also can lead to hiatus hernia because this is loosened and that lets some of the stomach come through as well as some of the acid. And all of these gut effects are actually treated in the NHS by the medications that cause it in the first place. Does drive me crazy, but I live with it, Yes, so there's a lot you can do about low stomach acid. Not something that I can really cover in depth here, but yes, certainly taking acid can be part of that. Yeah, long story. Let's look at pancreas inflammation. So if there's poor digestive enzymes, this is a sign of pancreatic inflammation. And it is, one of the tests that we can do is fecal elastase, so stool test to look for elastase, some of the pancreatic enzymes, and they're a marker for all the other pancreatic enzymes as well. So pancreas inflammation can be represented by high glucose developing into diabetes and insulin resistance. It could be represented by the triglycerides being high, such as we've seen with insulin resistance. And some of these other things can be used to spot it as well. And a low albumin, again, if the pancreas is inflamed and we've got poor digestive enzymes, we're not going to absorb our protein properly. Now let's look at the cardiovascular markers. So the routine ones that your doctor will organize are cholesterol, triglycerides, HDL, and LDL. Now, HDL stands for high density lipoprotein. This is the group of lipoproteins that are beneficial. And the more you have, the better. They increase the flexibility of the cell membrane, and they enable they help reduce the risk of heart attacks and strokes. So that's a good thing. You can increase your HDL by increasing seeds and nuts and oily fish. Triglycerides, as we've said, this is if the triglycerides are raised, it's a sign of insulin resistance. But statins don't make an impact on triglycerides. They just reduce your LDL, and they often reduce the HDL as well. And they definitely reduce coenzyme Q10, which is why statins often cause the side effect of muscle pain, because we've actually depleted the body of an essential nutrient. Ah, yes, Michelle, it's very common for heartburn to start when you're pregnant because of the extra pressure on the diaphragm and the stretching of the diaphragm by that lovely little baby developing in our tummies. Right. Other cardiovascular markers, CRP, that's a standard one that your GP can request, but highly sensitive or HS-CRP is something that we can't really request. So it's Interesting. Homocysteine. So this is the one I was talking to you about. That's a sign of uh, homocysteine is a sign of B12 and folate deficiency if your homocysteine is high, and it does increase your risk of heart attacks and strokes. Oxidized LDL, VLDL, which is very low density lipoprotein. So when we're talking about lipoproteins, that means a molecule that's created, that's made up of lipo and protein, so fat and protein combined. So these lipoproteins are fat protein combinations. And then we have fibrinogen. And fibrinogen is an important test that we're not really getting done. However, if you have had a certain vaccination, or if you've had COVID itself, I do recommend you get a fibrinogen test, because people are finding that either after the vaccination or the infection, their fibrinogen levels are increased. And that's why we have seen a lot of vascular events and clotting events in those individuals. And then this new thing, the calcium CT score, which you can request privately. In the insurance and health systems, only the cardiologist would be allowed to request it in the system, but you could get it done privately, depending on what country you're in. Of course, I believe in Canada, it's quite difficult to go privately with these things. Sometimes it's easier from Canada to just pop across the state boundary to the US and get things done. So highly sensitive CRP is much more specific, but in the UK, only cardiologists request it. And so this is a little bit more about those lipoprotein particles. So when you get an advanced lipid profile, you get so much more information. You get your standard lipid panel, but you also get this LDL pattern density. Here are the LDLs here, and we're looking at the lipoprotein little a and apolipoprotein B, and LPPLA2. These are giving us a much more sensitive approach to people's cardiovascular risk. It's not something that we can do in the NHS as things stand, but to actually have this information and then pair it with your genetic analysis is brilliant for seeing what is your situation, what adjustments to your diet and lifestyle will make a big difference to this, and you can observe it by repeating it 6 months later. And also what genes are involved as well, so it can be really helpful. Now, blood sugar ideal markers. As I've said, I'm passionate about insulin resistance. We want the fasting blood glucose to be 75 to 85 in the US, or 3.6 to 4.9 in other countries. We want the HbA1c, which is that hemoglobin A1c that's got this glycosylated hemoglobin. So you've got a glucose molecule stuck to the red blood cell. And you want that to be between 4.5 and 5 if you're in the US, and 26 to 31 in the UK, and standard international. So Europe, Canada, South Africa, I'm not sure. So what you want to be doing is getting this lower through the diet and lifestyle changes that we recommend, and we can do that. So mine is currently at 33, despite my strong family history that I explained to you. But if I ate like my mum, I'm sure I would be in the 41 to 49 level for sure. Triglycerides, as I say, this is a sign of the triglycerides is literally 3 glucose type molecules stuck together, triglyceride, and the levels, this is US markers, I'm afraid, but the levels, you want them to be as low as possible. We don't want them to be in these high levels that we see. And that can be reversed, but in general practice, we don't know that they can be reversed. And then the fasting insulin, we want it to be between 2 and 5. C-peptide is a joining peptide that's sometimes requested by diabetologists. The insulin molecule is, let me just see what I'm showing you. So the insulin molecule is 2 peptides joined together by C-peptide. And so when it's broken down, that leaves the C-peptide. So that's where C-peptide comes from. Fructosamine, we don't tend to use that in the UK anymore. It used to be used instead of the HbA1c. But because this gives us 3 months history, this only gives us 2 months history. This is a much better way of looking at someone's diabetes control in the longer term. And we can now use it for diagnosing diabetes. And then antibodies, again, which we don't tend to ask for in the medical establishment, but we can do with our private access. And here are the US versus standard international markers that I've worked out for you. So again, standard international optimal is 3.6 to 4.9. And then for HbA1c, you want it to be between 26 and 31. And here's a bit more of an illustration of hemoglobin A1c. So it's an indirect measure of your blood sugars over a 120-day period. So if you have a low HbA1c, the red blood cell would, figuratively speaking, look like this. But with a high HbA1c, it would be looking like this. And this is an irreversible change. So those sugar molecules, once they're attached to the red blood cells, they're not going to leave it. Once they're attached to the hemoglobin, they're stuck. However, because the red blood cells only have a life cycle of 90 to 120 days, that's why you can make a difference to this. So you can start changing your diet and your lifestyle and your stress and all of the things that we recommend in functional medicine approaches. And that will enable you to reduce your HbA1c and therefore reduce your risks of all the things we've talked about: dementia, heart disease, strokes, cancers. I've also done an HbA1c conversion to average blood glucose. So in the UK, if your HbA1c is 31, your average blood glucose is 5. We actually don't want it to go above 7. Whenever it goes above 7, it's easily going to be causing retinal damage and kidney damage. But that's the level at which we would diagnose pre-diabetes in the UK. So estimated average glucose, I'm just going to mute myself a moment. Right. Ivy has been taken away by my dear husband. Bless her little heart. Yes. So estimated average glucose in US terms, we want, if your HbA1c is 4, then your average will be 58. So this is your average, which means it's been spiking higher and lower. And we ideally want it to be stable. We don't want it to be spiking high and low, because every time it spikes high, that will cause damage, as I say, to the tissues. So some of the negative effects of this insulin resistance include increased body fat. So if any of you are feeling some weight gain around the middle, especially happens to us women in our 40s and 50s, it's insulin resistance going on. Damage to blood vessel linings, elevated inflammatory markers like ESR and CRP, and that means there's elevated inflammation. So when you've got insulin resistance going on, you'll have more muscle and joint pains going on. So you'll have more fibromyalgia. These things can be improved, but not if you wait until things are abnormal with your traditional approach. And insulin resistance also causes high blood pressure and decreased growth hormone and thyroid hormone. I now have 2 black Labradors up here. Very illegal, because we're in a holiday cottage where they're not allowed upstairs. But as I say, I left the gate open, so more fool me. Let's just go back a little bit. Yeah, so 90 to 120 day change possible. Absolutely. We've seen it many times. I've seen it many times. Absolutely. So, and also with insulin resistance goes hand in hand other things like decreased growth hormone, because insulin and growth hormone are like arch enemies. And if you increase your insulin levels, for example, if you eat close to going to bed, you're going to increase your insulin, which means you won't get any growth hormone overnight. And you want your growth hormone to be active overnight, putting on muscle instead of fat. And then the thyroid hormone. So thyroid hormones, all these hormones interact. Some of these other hormones cause estrogen receptor resistance, thyroid receptor resistance, progesterone receptor resistance, testosterone problems. They all interact. So there's these negative effects. And then we really, as I say, we want the postprandial or after meal glucose test results to remain low. Now, one of the problems with the medical establishment is we tend to only measure the blood sugar before meals and 2 hours after meals. And that is a standard. That's how things are done. And yet, if you actually look, your blood sugar spikes in between times, and it can spike between Mine usually spikes at 45 minutes. And the way to tell this is either to measure your blood sugar frequently, even if you're not diabetic. I recommend that you measure your blood sugar on a frequent level basis after meals, so that you're looking at when your high point is. And you can then test different foods, different lifestyles. You can test what happens when you're stressed. You can test what happens when you have a bad night's sleep, whether it's intentional insomnia like me when I'm doing a launch and preparing a masterclass, so going to bed at 1 a.m, or whether it's insomnia because of hormones and the anxiety and not having learned all the self-care things that I recommend and have learned myself. But those will impact your blood sugar and will impact the way your body responds to meals. What's even better now available are the continuous glucose monitors, CGMs, and I recommend the Freestyle Libre. It's worth it. They're expensive. It's worth getting a couple and just observing your blood sugar continuously for 2 or 4 weeks. And then you can test different foods without worrying about remembering to prick your finger, and you don't turn into a pincushion. Now, I've got another couple of segments ahead, and also I have got which I forgot to mention at the beginning, more fool me, I have got a prize for those who are staying to the end of the masterclass. I have got a really useful PDF download of lab tests for you to download, which I'll give you the link to at the end. But right now, we're just going to take a little commercial break. I'm going to, as I've said, I can tell you I can tell you a little bit floating over the surface here and now, but I can't go into the depth that I would like to. And I would like to show you some software. You've seen how complicated these lab results are, and how something can be a sign of low zinc or something can be a sign of low selenium, but how do you integrate that? Fortunately, with artificial intelligence, a friend of mine who's a naturopath has created an amazing piece of software called Optimal DX, which brings all these results together and helps us to understand things. And I'll show you what this means. Oh my goodness, Otter's going to close at an hour and a half. Right. So this blood chemistry report is amazing. So functional body systems, functional approaches to our health. As I've said, we're not looking at just what's the national normal. We're looking at what is optimal health, and we can calculate results from bringing together these different blood test results. So you've seen how complicated they are, but I like to use this software because it helps me in interpreting people's results in a much deeper way and a much more actionable way, because it enables you to see what your next steps are and where to focus your support. So this is the first screen that we have in the software, that we can choose the default female or male template. We can choose conventional US units or standard international units. I still find that I have to do some manual conversions. And then this is the page on which we actually add the values. So we would add the values here. It will flag up if it's high or low. And so we put as many blood tests as we can from the same date. If you've got 2 blood tests that complement each other on different dates, I will often put them together just to give that overall value, because it helps us to see. But that's best if they are as close as possible in date. And then once we produce that, it produces a report. And I'm just going to show you, because I did. Let's have a look. Here's Chrome. Ooh, we're in the way. Oops. Just bear with me while I find how to move this out the way. There we go. Right, here we go. So this is so for each person, I get a practitioner printout and a patient printout. So this is a simplified version, because as you've seen already, this stuff is complex and you may not want to be looking at it in as much depth as we do. But it's a beautiful printout that gives us some information. It explains what functional blood chemistry analysis is and why we are looking in this more depth than just normal, and why we're looking at optimal ranges. It's giving an overall functional health report. And then we go to the actual assessment. So this is the patient report I'm showing you at the moment. And this is mine from a while ago, 2016 values. And even so, I haven't got the amount of depth that is optimal because I didn't have some of the blood tests in there. So it's ideal if you can get as many as possible done. But it's just beautifully set out. And I'm just going to skip back to the presentation because... okay. That's why. There's where we were. Okay. So for example, we can see here, I'm going to move this out of the way. I can minimize it. I know you can, but just moving that out of the way. So we look at all of these values and we can place them. So you can see here that this reading in the darker blue is 89. So it's outside the optimal range, but it is within the standard range. And there'd be a different color like here. There'd be a different color if it was even outside the standard range. So this one was within the optimal range. I tend to use the traffic light colors rather than the blues. Beautiful though the blues are. It's not an app, it's a practitioner thing, Lizzie. So here we have the levels, and you can see the optimal range and the standard range, and the traffic light system actually shows you in red, amber or green, so that's easier to interpret at a glance. And then we have a key here which shows what's optimal, below or above optimal, below or above even the standard levels, and even alarm levels. So you can see here that somebody's blood glucose is above optimal, but within the standard range, for example. And this is me looking at someone's results. And here we've got a TSH that's well below the optimal and below the standard. And it's at an alarm level. And it just helps to make it easy to interpret things. We also look at things side by side. If you've got more than one lab test, we can put both sets in and compare the trend. And this can help you look. It can load up to 7 sets of test results at once. And so we can look at what's happening over time and how you're improving your hemoglobin A1C or not, for example. And then we also have functional body systems that it looks at. For example, here you can see that the thyroid function is in the alarm stage, and then the kidney and liver function still needs some help as well. And in this particular example, again, if you're looking at possible being 50%, we really want to take action on all the things that are above 50% risk. So this person has, this woman, because it's female sex hormone, they need some support with cardiovascular, GI, blood sugar regulation, immune function, liver function, and thyroid function. So helpful to be able to focus your attention. And then we have nutrient status. So we can use these blood tests, as I've outlined, to look more closely at vitamin status, protein status, and mineral status. And here we've got the global levels. And then we can also look in more depth at the actual vitamin D, calcium, thiamine, magnesium, for example. So you can see how powerful this report can be. And then we also have a fan-shaped analysis as well, which helps us. And also this page also shows us what next blood test would be a good idea to add in. So it helps to guide you and your practitioner. So I'd like to share with you, if you'd like to know how to get this report run on your own blood, do you think that would be useful to you? Do you think it would be useful to have this much depth on your own blood tests? Just type in the chat if you'd be interested. Yeah. It's so insightful. Absolutely. So, and also I have a package that can help you to understand what your blood test report means. So rather than just having the blood test report, which you've seen is very full, also to know what to do about it. So I'd like to introduce the blood chemistry review consultation with a computerized report. It's my new package that I'm launching this week. And what's included in it is, first of all, you get that computerized blood chemistry report that gives you a detailed functional analysis of your existing blood test. It helps to identify potential organ and hormone dysfunctions and nutrient imbalances and any follow-up testing recommendations. We also have a 90-minute lab review or strategy session with myself or one of my health coaches, where you get to discuss your health history, get your questions answered one-on-one, and receive more tailored one-to-one direction based on the results of the lab test. And that's worth £500. And we also get a food and supplement plan for addressing the imbalances that we identify. And you'll also get that guidance on the most appropriate next steps for you, including any additional laboratory testing indicated, although no blood test costs are included in this. So we're looking at either your existing blood tests from your primary care physician, or I can share with you how you can order them if you want some, if you actually want to access that. And the total value of this is £900. So I'd like you to consider what your health issues are costing you at the moment. They're costing you in terms of direct costs, so in terms of cost of medication or supplements or seeing the doctor, hospital admissions, the cost of seeing complementary practitioners to help with any chronic pain that you're dealing with and other symptoms. You also have costs that are more indirect, so the cost of not being able to be at your best, not being able to. It's costing your relationships. It may be costing your relationships in terms of you having brain fog every morning or being short-tempered because you're in so much pain. And it's costing you in terms of your business if you are self-employed, or in terms of your chances of promotion, or even risks of demotion and being made redundant if you're not able to make best use of your energy, if you're suffering from brain fog and headaches. These could all be costing you in many different ways. So as a result of this blood chemistry review package, you will get to identify imbalances before they become diseases. So you'll see if you've got insulin resistance like me, you can start taking action before they become diabetic. If you're already diabetic, you will have some keys that will help you to reduce that. It will help you to identify nutritional deficiencies and toxic excesses that may be present and that can be redressed by some lifestyle changes. It will help you identify immune system imbalances and prevent illness and prevent infections. And it will help you to identify potential digestive imbalances, as we've talked about with the stomach acid. It can help to identify inflammation and correct it before it becomes serious. And if you're already suffering from chronic pain, like so many people I see these days have fibromyalgia and osteoarthritis and just chronic pain, we can help to correct it. And we can also identify causes of low energy. And you can also have a roadmap of what your next best steps should be. So what's included, again, is that computerized blood chemistry report, a 90-minute lab review and strategy session with me or one of my health coaches, a food and supplement plan for addressing those imbalances, guidance on your next most appropriate steps for including any additional laboratory testing. And the total value of this is £900, and it's usually £750. That's the standard cost for this package. However, for those of you who are watching today, I am giving you a discount. If you go to this website, drali.com/lab review, which I'll share in the chat. I'll do that now, actually, and use the code BCA353. Bear with me. And then the code is BCA353. I'm giving you £353 off. It's only just over half price. So amazing opportunity there. So we're going to now, and I was mentioning that offer early on because of the fact that so many people have to get away, and I know some people just needed to know earlier. So anemia, some of the types of anemia. So First of all, iron deficiency. This is the commonest form of anemia that we see. We usually recognize it because it's microcytic. Micro means small, cytic means cells. So this is when the red blood cells here are smaller than usual, the round ones. So when these are smaller than usual, it's a sign of iron deficiency anemia. And then folate and B12 deficiency, that is represented by macrocytic anemia, macro being large. So in here, the red blood cells are larger than usual. And this is the mean cell volume, the MCV on your full blood count and differential. And then the vitamin B6 deficiency. So the folate and B12 deficiency, so the vitamin B6 deficiency is another thing that can cause anemia. Hemolytic anemia, which is where the blood cells actually hemolyze or burst. And then aplastic anemia, which is often due to a bone marrow issue. It can be caused by medications, and it tends to be associated with a loss of all the cells. So you may find that you have low white blood cells as well as low red blood cell count with aplastic anemia. And then sickle cell and thalassemia, which are genetic. So when you have the homozygous sickle cell or thalassemia, it can be fatal. But more often, but people who are heterozygous, which means they have one normal gene and one abnormal gene, will have a different issue. So people who are heterozygous for sickle cell, these are the sickle cells that occur with the homozygous, but they have protection against malaria, which is why sickle cell hasn't died out by natural selection. Thalassemia tends to present with an anemia with small red blood cells. And there's thalassemia alpha and beta, and there's TRE, which is the heterozygous version. And then there's anemia of chronic disease, which we commonly see when someone has chronic kidney disease or chronic liver disease. They develop an anemia which isn't due to one of those deficiencies. Now, people are asking how much the blood tests cost. I actually deleted the slides on hemochromatosis because the talk was too long, Lee, but I will mention it for you. Yeah, the link's not working. Oh, is it really not working? Let me just check. Oh, God. Okay, I'm just going to stop my share and get that working. Excuse me. Okay. Thank you for letting me know. Fatal problem. Oh. You see, there are so many things involved in getting these things, so much tech. Right, going to find the correct page. Order form. Right, sorry about that. You should find it works now. And let me know if that special code doesn't work as well. Okay, so now I'm going to share my screen again. And types of anemia, here we go. Right, so that's types of anemia. Yeah, so symptoms of anemia, Commonly fatigue, weakness, headache, shortness of breath after exercise. And in fact, my mum had angina at some points that were just because of anemia. And once she had an iron infusion to make up for that anemia, the angina settled. So anemia itself can cause angina if you've got slightly furred up arteries that won't give you any symptoms. Just a little bit of anemia where you're not getting enough oxygen to those heart muscles can cause a heart attack. Pounding in the ears, brittle nails, very common. Pallor, palpitations, dizziness, cold hands and feet, and also angular cheilitis, where you get cuts at the corners of the mouth. That can be anemia. It can also be oral thrush, or it can be thrush, but it can also be due to anemia. So lots of different things. And the most important blood markers are, we really focus on the hemoglobin, the hematocrit, and the mean cell volume. And the red cell distribution width, this is interesting because this is the variation in size. If you've got a wider red cell distribution width, then you may have small cells and large cells. So, for example, you'll have a much higher RDW if you have a combination of anemia, of iron deficiency anemia with small cells and B12 deficiency anemia with large cells. So that's where the red cell distribution width is important. And some of the blood markers of iron deficiency include that we can do, if the hemoglobin is low, we can go in a bit more depth and look at the actual iron, the ferritin level, which is the storage form of iron, although it is actually an inflammatory marker as well. Transferrin levels, total iron binding capacity, which is the available transferrin to bind the iron. Transferrin saturation, and that looks at how much iron is actually bound to the transferrin. So these help us to look in a bit more depth at your blood markers. And here are some of the causes of anemia: pregnancy, worms and parasites, autoimmune disease, very common, heart disease, chronic infection, kidney disease, then medications, which, especially if they're causing some bleeding, such as anti-inflammatories, a lot of antidepressants cause gastritis and bleeding, and anticoagulants may cause low-grade bleeding as well, and then serious illness and cancer. And as a medical doctor in the system, the first thing we're looking out for when somebody has an anemia that we can't explain by other means is to make sure it's not cancer. And then there's insufficient dietary iron, folate, B12, or fatty acids, and low stomach acid as well. And of course, heavy menstrual bleeding or menorrhagia. If you're having heavy periods, which is very common for us women in our 40s and 50s, that can cause anemia as well. And some women experience anemia all the way through their lives if they have heavy periods. So sometimes the numbers can be a little bit off. If you've got high iron and low ferritin, which sounds a bit of an anomaly, that could be low melatonin. If you have high iron and low hemoglobin, again, unexpected, that could be B6 deficiency. And if you have low iron but high ferritin, it's not just because it's the iron stores that are high, but because it's a liver-based inflammatory marker and the liver is releasing it when it's inflamed. And hemochromatosis is when you have a high iron and high ferritin. Hemochromatosis is one of the commonest genetic tendencies that we have in the Western world. Just check that. Okay, so the discount code isn't working. I'll get to that at the end if you don't mind waiting. Thank you, Lee. Okay, yeah, so hemochromatosis is a problem where you have high levels of iron, high ferritin. It can actually cause liver damage. It tends not to give you symptoms as a woman until you stop menstruating. So it tends to present in women after the menopause because we're naturally losing blood every month. But for men, they tend to get it earlier and need to have give blood on a regular basis to reduce the iron levels in the body. And so in these cases, giving blood can actually be therapeutic for the person giving the blood as well as the person receiving it. So that's hemochromatosis, but it can lead to cirrhosis and diabetes. So it's a problem. Yes, like leaching, absolutely. So suddenly gives you a reason why leaching might have had a therapeutic advantage after all. And I always thought that was so strange. There we go. We live and learn. So B12 and folate anemia, you'll see decreased hemoglobin and these other things decrease, but particularly the mean cell volume will be increased. I'm going to speed up a bit because time is moving on. And then there's the anemia of serious illness. Such it may be like iron deficiency anemia, and we're always, as I say, looking out for this, because iron deficiency anemia due to bleeding, the bleeding can be due to bowel cancer, lung cancer, any cancers can cause iron deficiency. But your total iron binding capacity and transferrin may be increased, and there may be other symptoms, so we're looking for other areas, so we need to be looking for these as well. Immune system. So first part of the immune system we're looking at is, again, with the full blood count or complete blood count. And in the UK, we always do the differential. So we have the different subsections of white blood cells. But in America, you may need to ask for that and make sure that's being done. Neutrophils are a sign of bacterial infection. They are also known as polymorphoneutrophil leukocytes, and they engulf bacteria. So that's why they increase if there's a bacterial infection. Lymphocytes are a sign of a viral infection because they are the ones that release antibodies. So they are increased when you've got a viral infection, which is more managed by the body with antibody production. Monocytes can be representative of the recovery stage of illness. So when you're recovering from glandular fever is the obvious one, infectious mononucleosis, you get raised monocytes then. Basophils can be a sign of a histamine problem and certain allergies, and eosinophils are classically raised in asthma and eczema, and also when there are parasites on board. Then, so with bacterial infection, what you'll see is usually a raised white blood cell, particularly the neutrophils. With a viral infection, you'll see a raised lymphocyte count, although you can see a lower lymphocyte count in viral infections, but the neutrophils will be depleted or unchanged. With parasite infections, you could see a high white blood cell count. Generally, the eosinophils is the main marker that we'd be looking for with that, but it depends on the parasite. There's so many different ones. And then inflammatory markers, CRP and highly sensitive CRP, ESR, and these are the two things that we measure most frequently that represent inflammation in the body. But that inflammation could be due to arthritis, it could be due to muscle pain, it could be due to inflammation in the gut or the brain, and it may be due to cancer. So if it's sky high, and it may be something called polymyalgia, very, very common in the over 60s. But so we've always sort of got half an eye open if the ESR is very high to see what's causing that. And homocysteine is another inflammatory marker, which can be reduced by having the right supplements and foods. High viral titers, such as EBV, as commonly occurs in ME and CFS. So Epstein-Barr virus is commonly a contributing factor to chronic fatigue syndrome, but likewise, you get a similar syndrome with long COVID, where it's a different virus that's caused it, that's a contributing factor. These things tend to be multifactorial. They tend to have lots of different things contributing and maintaining the chronic fatigue. And so if we can get to the root cause, understand the root cause, but also support the mitochondria in creating more energy, then that can help with your recovery. And then I've got a little bit about the thyroid here, and just a little bit. The thing about thyroid, I'm passionate about thyroid, being affected by it myself, my mum having had it, and the way it's so difficult to be both an NHS and a functional medicine doctor, because in the NHS, even with everything I know, I can't actually request the free T3. And ideally, I'd like to have the free T3, the total T4, and the TSH. As well as both types of antibodies, but we can only request the thyroid peroxidase antibodies in our system. We can only request the TSH, and we can't request these. The lab will decide whether it's going to measure these, and that's depending on the TSH results. So if the TSH is NHS normal, then these won't be measured. Now, this is interesting because the lab range is 0.3 to 5.7 for TSH. I would say more 4.5 now. So I would say in our health system, if it's above 4.5, it would be flagged up as abnormal. But that doesn't mean to say the doctor will do anything about it, because it's still considered subclinical. Now, when it's subclinical hypothyroidism, what I find is people are already experiencing obesity, feeling the cold, slowing down, weight gain, hair falling out, especially the outer third of the eyebrows, and hair getting frizzy, skin getting coarser. They're not subclinical, because subclinical officially means no symptoms, subclinical. But in actual fact, these people very often have multiple symptoms and are really suffering. However, the other aspect of the NHS or medical establishment approach to thyroid illness is they don't believe or know how to do anything. They don't believe that anything can be done about raised antibodies. They don't believe that it's important. They don't believe that it's important to reverse it. And so they don't recommend measuring it. And antibodies are the body attacking the thyroid gland in this case. They can be reduced by the fundamental functional medicine approach to health, healing the gut, and so much more. So there's a lot you can do to reduce the antibodies. Now, the ideal range is 0 to 2, but very often in our systems, that only gets reported as being less than 11. So we don't actually know whether it's in the ideal range or not. And that is how things are. Now, the significance of this T4, T3 issue is the thyroid gland creates T4 in the main, and it's in the rest of the body that the T4 is converted to T3. And T3 is the active form of the thyroid hormone. It's the form that is 70 times more active than the T4. This is the really important hormone. But in medical establishment systems, we can only treat it with T4. So if your problem isn't that you've got a low T4, but it's that you've got a low T3 and your body is not converting from T4 to T3, just replacing T4 as we do in the medical establishment systems isn't going to make you feel better. And that's why so many people are wandering around on thyroid hormone T4, levothyroxine, and still feeling absolutely grotty. And there's so much you can do to help that, to understand it more, and to get that sorted. And reverse T3 is a hormone that's the mirror image of T3, the active form, and the body produces reverse T3 when it needs you to slow down. So, for example, if you are recovering from an accident or from major surgery or from a viral infection, or if you have chronic fatigue syndrome, you'll find that you have a higher level of reverse T3 and less of the total free T3. And this will affect how you recover. Okay. So a couple more results. So yes, those are pretty much UK ranges. Last TSH was 0.86. Free T4 direct was 0.87. That's good. That's good, Michelle. NHS won't test my antibodies again, even though I have Graves. And it's a different antibody. We really need the Graves antibody in that. I tried to request it the other week and I wasn't able to. Hey ho. Do you have Armour-thyroid in the UK? That's the one I take. Yeah, that's great. So basically, I do in my bioidentical hormone replacement therapy practice, I do use Armour-thyroid, but it's very much frowned on by the medical establishment. And I may have to stop because of the way that the medical establishment is going in this respect. Yeah, Hashimoto's, they can't be changed, so there's no point. Wrong, absolutely, Lizzie. Right, so I'd like you to take control of your health. And I'm just going to go through that offer again. But while I do that, I'm just going to, levels on the top, what I look at for Graves. Yeah, it's a different antibody for Graves. So bear with me. I'm going to stop the share, do a little bit of back office stuff, reactivate that code. I must have put a time limit on it. Bear with me. So let's do Graves' disease. There we go. It's the thyrotropin receptor antibody. I'm going to paste that. Now you can try and get it done in your, by your usual doctor. This is the one for Graves' disease. And anybody listening to the recording, it's the thyrotropin receptor antibody that's needed for Graves' disease. Okay. So the blood tests. Now, I have got a document where I've assessed how much there were, but they didn't include all of them. Let's just get the code reactivated first. So back into my keep. Here we go, logged out. Okay. Promotions. I said between the 13th and the 30th. So it should work. Okay. Right. So what I'm going to do is share my screen and show, and we can see together whether that code works. All right. So back to Chrome. Here's the order form. Okay. And you can see where it says have a promo code. Fingers crossed. BCA353. Oh, it didn't. BCA353. Apply. Yes, there you are. You see, so there's the code, and it does work on that website. Okay, on that order form. All right. So the code's working. Yes, well done, Lee. Which levels I would look at on for the T4 and T3 on your chart. So the levels are 22 and 10. So, okay, free T4 is 22 and free T3 is 10. Well, let's change. Oh, it's all one share, isn't it? Share screen. So if we go back into the, here we go. So go back. Right. So just going to bring that up here. So your free T4 is 22. Free T4 is here. So, right. Okay. So, and which country are you in, Lee? Are you in the UK? What I think it is it's the equivalent is 2.2. So you'll probably find that it's nanograms per liter or micrograms per DL or something. So it's a factor of 10. All right. So yours is 2.2 for the free T4. So it's just above normal and certainly above the ideal. And then the T3 was 10. And was that free T3 or total T3? Oh, it's free T3. Excellent. So the free T3 of 10 is equivalent to 1.0. So you've got a low level of free T3, either from the ideal or from the lab range. So you're not converting from T4 to T3 adequately. Your T4 is high and your T3 is low. So this is exactly where you need to sort of go in a lot of depth into T4 to T3 conversion and autoimmunity. Okay. So now blood tests. I'm going to stop the share while I find my blood test website. For those of you in the UK, and I can arrange it in the US as well and in other countries. So I'm just going to have a hunt, functional medicine, Nordic. This is the website that I use. So tests. And these prices are subject to change, of course. But if you let me know what you have and what you want, we can sort that. So searching, first of all, for thyroid. Just refreshing. Right, so the comprehensive thyroid profile is £273. And that includes includes iodine status, which is what's so special about it. It's not saying, but it doesn't include the reverse T3, I'm sure, but it does include all of the others. So 2 antibodies. I'll have to look that up later. Okay. And then if we go back, now I have a comprehensive female blood profile that I've highlighted that includes thyroid. Okay, so this includes estrogen. This is blood spot, which have been shown to be less accurate, but at least to give you an idea. So that includes estrogen, progesterone, testosterone, sex hormone binding globulin, TSH, free T3, free T4, and TPO antibodies, but also DS and C. That's 273. What I'll do is I'll research it and send it out in an email to everybody who's listed as attended. Okay. Right, I'm going to stop the recording now. Thank you, everybody, for joining me for today. And I hope that it's opened your eyes to what's possible.